about what you wish you would have known. Someone would have told you before you hit the floors for the first time. Please.
There's going to be a lot of time where you will just be waiting, and you have to get used to it and not be upset by it, because that's healthcare.
Charlie?
There's going to be a lot of times where you feel very awkward, but it's okay. It's all going to be okay. I mean, like, you'll get on a new team and you won't know what to do, but you'll be expected to know what to do, and you just have to figure it out. And then once you figure it out, they'll switch you to a new team. That and a lot of your first patient experiences, you know, will be kind of strange.
Train wrecks stuff.
So what are you going to do with your spare time on the floors?
Bring something to study with. That's what I got here in my pocket. So you always have something to do. Or bring like study PDFs in your email so you can pull them up on your computer or something like that.
Good call.
I think what made you most nervous?
You don't really know the expectations, to be honest. You hear what they are, and they give you a syllabus, but you know what you read and what you actually have to do is sometimes two different things.
This year is more about the things that maybe you didn't get tested as well last year. Your professionalism, being on time, having seen your patients before your team has, so that you get some idea of what's really going on with the patient.
Every day you're going to learn something new. Every day there's going to be a little bit of nervousness as you're starting to do something new, but it'll come to you.
Which sounds really scary, but it's not. Because your team will help you, and your residents, and like everybody will know, like, this is your first time on OBGYN, you have no idea how to deliver a baby, and then they'll walk you through the steps, and you'll do it the first time and be terrified, and then the second time you'll be a little less scared, and then like the fifth time you're like, oh, I can do this.
Which goes.
What advice would you give? Like, what are the most important things?
All you do is eat and poop. Wear comfortable shoes.
Oh, baby, it's still you I'm thinking of.
Been here 2 hours at least.
Which you were right about. You were like, you know, it's more suggestive of acalculus than it is of this regular stuff. So the endoscopic ultrasound is done just to see if there's microlithosis. Are we missing some stones? And if had they seen one, what would they have done then? That was the other ERCP, right? So that's why they would have done the ERCP after that. So that's negative. Nothing there, nothing on the ERCP. So you are even more certain than ever that he has acalculus in his studies. And you're sticking with that diagnosis.
I am.
Okay. Go ahead.
That's my story.
We didn't have coats and we walked in. We had shoes.
Uphill both ways. So, yeah.
Actually, where did we sleep?
Yeah.
We didn't sleep.
We didn't sleep. That's why we called residents. It was you stayed in the
hospital. Was it a lot, and I mean a lot harder back in our day?
I think they have it hard too. I always say that. And then
finally, an honest attending. Since you hear from everyone how much harder it was, you know what? He is right. It is harder because we put so much more pressure.
You ain't nothing but a hound dog.
Sure.
No, I think it's
So totally, what are you doing at the computer?
I'm going to log in and maybe see if my team got any patients. I'm on call today, so.
What does that mean?
So for medicine, you have short and long calls, and on those days, that's when you're admitting patients. So ER calls you, get a patient, you go see him, do an H&P, discuss it with your team, and then you present to your attending the next day.
9. Oh, okay. So you don't have to be here at 6 in the morning?
No, we get here around 7.
Uh-huh.
Yep, so we get here around 7 and we go do sign out, and then we kind of check on our patients for the day.
What's sign out?
Sign out is where you figure out what happened overnight.
And who tells you that?
The night residents.
All right.
The first thing I always did was come in and just read what happened overnight on the electronic medical record, and Epic's very easy to navigate, so that's great. You just kind of read everything that happened overnight, any notes are put in, look for any new lab values, any new images, kind of just get a good sense of what's happened since you were reading about the patient last. Then I always immediately after that would go see the patient just to kind of get their perspective, ask them how they were doing, get my physical exam, and then if I had time I would kind of come back in and start my note and just pen. It's a really, really good way to present because you know that's kind of the most current information. And then, you know, as you jot notes down during rounds that you're attending and your residents are throwing at you, then you can just go in, finish typing those up on your note, and then your note is nice and in early.
Does rounding for medicine or peds different from surgery?
Yes, it is. On surgery, there's a lot of patients, but rounds are done much more quickly, and the students rarely present. But you are expected to know about the patients that you are caring and following. On internal medicine and pediatrics, you'll generally be following, like Toli said, anywhere from 2 up to maybe 4 patients by the end of the year. You would be expected to come in early, as Grant said, and that could be up to an hour early. You look up everything that's done on the patients, and then you simply go through, and some attendings prefer to go into the room, other attendings prefer to stay out in the hallway, but you'll just go through and round on all of the different patients that you have. Presentation will be done by whoever's following them. Medical students tend to do the most presentations because this is a teaching hospital. And then you discuss as a team and come up with a plan for that day for the patient.
Love me tender, love me sweet, never let me go. You have made my life complete, and I love you so. Love me tender, love me true, all my dreams fulfill.
A 2-minute presentation, get right to the point, get right to the facts. And there is the half-hour presentation or 20-minute presentation where you really go into lots of depths, and you have to know when to play each one. If a new patient comes in and says, this is so-and-so, he came in last night and had a heart attack, the cardiologist is going to be like, well, what's the rest of the story? But if it's the 4th day and you come in and you're still giving me the family history, I'm going to kill you.
Take all of that information you learned to take in your 2nd year, and you're going to have to learn how to make it succinct and give it to the attending in a way that he's going to say, good job.
What is an assessment? How is that different than a problem statement?
An assessment is after you've compiled everything and you think about it, you make a diagnosis and turn it into a medically term, and you say, this is what I think is going on. So a problem statement is like, this guy has chest pain. And then assessment is, this guy has chest pain after he eats spicy food and it goes away with antacid, so he has acid reflux.
You should come up with your plan in conjunction with like your residents. Your residents will help you if you're totally confused, and you'll use UpToDate in your textbooks, and you'll come up with a plan you'll discuss with your resident, and then you'll go to rounds and you'll talk about it. But to copy what your attending said the day prior, that is a no-no.
You write something in your note, if an attending writes something in your note, and then it appears the resident or student hasn't read it, we don't like that.
I had somebody at County that wanted specific numbers, and it was all in her note. And if you didn't read her note, then you didn't know. And she was like, why didn't you look at my note? Okay.
The attendings would say that I was very quiet.
So how would you change that?
I probably would have spoken up a little bit more during rounds, even though I felt like I was slowing the team down when I did. It's better that the attendings get to know who you are, that you have a voice, that you have opinions about what happens to your patient, instead of just going through your resident to talk to the attending.
If your patient has an MI and you literally know nothing about an MI, yeah, that's going to look bad. But if you get asked a very tough question and you get it wrong, but you're excited about the fact that you're learning a new piece of information, the attendings will love that. They just want you to be proactive and part of the team and not a wallflower.
Yep. Act like you want to be there. Act like you want to be there. Act like you want to be there.
When you're on surgery, if a surgeon ever asks you, do you want to do something? Say yes. Don't say, I could, because they don't want to hear that. Say yes. Say yes. Say yes.
To be a good student is to be a good team player and participate in probably every activity that there is on the floor with your team.
Bless my soul, what's wrong with me? I'm itching like a man on a fuzzy tree. My friends say I'm acting wild. I can't do this all on my own. I know that I'm no Superman.
That's backwards. I'm bugging your ears.
The most important thing is to be a team player, because you, as a team of like 4 students in your rotation, you're only going to be as successful as everybody plays their part and does their job.
If you miss PEMP questions, or if you don't know the answer to everything, that does not mean you're not going to get a fantastic evaluation. The key to a fantastic evaluation is being a team player.
So if you know the answer and the other person doesn't, I mean, eagerness is good on the floors, but if you jump in too soon, you leave the impression that you're throwing the other person under the bus, even if you know like what's going on. So you just want to avoid that.
This is kind of long, but I'm going to say it. Medicine is a team sport, and 3rd year is the only time where you feel like you're pitted against other people for like the rest of your career. But act like it's the rest of your career right now, because I started at Cook County Internal Medicine, and I was terrified, and my partner Dara, she and I, we didn't get everything right. But we worked together. We helped each other out. We weren't pitted against each other. We were totally helping each other out. And our attending gave us the most amazing, both of us, evaluation at the end, because he just appreciated the fact that we both worked together and we wanted to be part of the team and we were excited. And I got like straight fours from that attending, and it wasn't because I got every question right.
I think the first thing I would stress to everybody is that the nursing staff are probably one of the key members in your team, and respect for both the nursing staff and the ancillary staff that you have on the floors.
Threw a party in the county jail. The prison band was there, they began to wail. The band was jumping and the joint began to swing.
Do you pimp students?
Absolutely.
You do?
Mm-hmm.
Why?
As a teacher, I know the foundation of successful learning is humiliation, tears, and fear. And that triangle is strong.
That is a strong triangle.
No, we pimp because we love you. No, we pimp because it's the Socratic method, and we want to make sure that you are thinking about the problem. And we all, if you are asked no questions at all, that's a bad sign. If you're not pimped at all, that's a bad sign. It means either A, we think you're not interested, or B, we think you don't have enough confidence. Both of those are not what you want to be. You don't want to be the person who doesn't have confidence, you're being too shy, and you don't want to be the person who looks uninterested. Because then we're not going to try to draw you out. So we're trying to draw you out. We're not trying in any way to. What is the correct answer to the pimp question you don't know the answer to?
Well, that answer would be, I don't know, but I'll look it up.
Yeah.
And get back to you.
Concur.
Back to me, back to me. Oh, that, coming close, that's a tear in my eye. That's what that is.
Whenever you see a patient, really go home that night and learn as much as you can about their disease and about management and treatment. Because a lot of times I would have a patient, let's say with atrial fibrillation, and I would read up a little bit about atrial fibrillation, but then I would go back to my Step Up Medicine book and I'd start reading from page 1 and just keep reading. But what I should have done is gone back and spent the entire day just reading up on atrial fibrillation, because the next day your attending is going to come up to you and pimp you really hard all about atrial fibrillation, management, treatment, prognosis, and you'll look like an all-star if you actually went home that night and read up as much as you can.
I used to think that it was bad and it was really stressful until it was the things that they pimp you on that stick with you the longest, pretty much. In the end, like, you'll remember it.
Watching you pimp students?
Hell yeah. No, not that much, right? A little bit.
It's all fair.
What do you think of the words "I don't know"?
I think it's completely fine. I think it's completely fine. A lot of stuff I don't know, so I tell them that all the time. And
So you role model.
Going and going to see how deep your knowledge is, which is a good thing. I mean, that's a good thing. Like, and for most of these topics, we could go deeper and deeper and deeper and deeper, and we can find out: did you read Up to Date? Yeah. Did you read Wikipedia? Or did you read the New England Journal based on how deep your knowledge is and if it's just a superficial understanding or if it's a much deeper understanding? And, and then when you come back the next day, you can say, well, I found a randomized controlled study from the New England Journal. What's the difference between direct and indirect bilirubin?
Okay, well, direct bilirubin is the conjugated form of bilirubin.
What do you mean by conjugated?
UGT enzyme, I believe, is going to conjugate it.
What does that stand for?
You're something glucuronal transferase.
Right, very good. Direct and indirect. Which one is more important if we're worried about liver disease?
We're worried about direct.
Why?
We want to see if the liver's actually conjugating it.
Okay. Whatever. Give me another example of a good liver test, but not AST or ALT.
Alk Phos.
Isn't that for bones?
It can be.
What else?
GGT.
Okay, very good. Now, what is Mrs. Smith's middle name?
I have no idea, but I would love to look that up for you.
Thank you.
So for on-call, I recommend bring extra clothes, bring a clean pair of socks and underwear, and shirt. Bring food. Sleep the night before. Hi. Sleep the night before. Sleep the night after, but don't worry about sleeping when you're on call, because that's not why you're on call. Hang out with your residents. Act like you're interested, even when you aren't, and you're tired and you want to go to bed.
Keep money on you. I'd always have a 20 in your pocket, because you never know when residents are going to tell you, hey, let's eat. Not the same as first and second year, staying up like how many hours until the test type of thing. You can't do that.
Right.
He's tested. It's just different.
And the most important thing I could say is focus on your patients that you're assigned to and know everything you can about them and what's going on with them, because those will be the questions you ask, and that'll be the way that you show your caring, is by really knowing a lot about your patient. Yeah, you can do all the peripheral stuff here and like read up on your patients and all that kind of thing here. Don't just sit around and play on the computer. Like, get it done. That way when you're gone, you feel like you can like kind of break away from the hospital a little bit.
Towards the end, after you've done, let's say I'm on internal medicine, after I've done 2 months of inpatient, by then I'll have read most of the book just by patients, because you see a wide range of different types of patients. So you'll read most of the book just based on your patients.
What's in your pocket, Mark? I see about 50 pens.
Oh, yeah.
What else is in there? What do you bring to get ready?
So yeah, we got our feedback cards.
Feedback cards, okay, right.
What else I got? I got my handy dandy Maxwell thing. I got M1 year. It still comes in handy
hold that up
every
for
now
me.
and again. What else we got? Gum. If you're a coffee drinker like me.
Yeah. Okay.
I like this too. This is good for medicine.
Oh yeah, I heard that was really good.
I would recommend
Made by
that.
Harvard.
You want a stethoscope for most rotations, except for psychiatry.
You know how they told you guys to buy those otoscopes?
Don't need them.
Don't ever use them.
Sell
Why?
them-
Because they
sell
have
them to the
them on
M1.
the floor.
Yeah, they have them on the floor, so I'd sell them to the incoming M1s.
Let's see. I have up-to-date articles on my patients.
This pencil?
I have one pencil. I have
Where is a
the
pencil? Seriously.
I have the list of surgeries for the day.
Lubricating jelly.
Ah, there you go.
You must have that in
At all
case your
times.
resident needs you to do a rectal.
Mr. Daniels, some fluid has gathered near your heart, so I'm going to schedule a pericardiocentesis and drain it with a needle.
Someone's going to stick a needle in my chest?
Not just someone. Dr. DeMann.
Who's Dr. DeMann?
Say it without the doctor.
Hey, Tully, what's the difference between being at County and being at Rush?
So part of it's just the way things are run. Food. Yeah, they actually have really good onion rings and curly fries, which County, I mean, you'll eat those every day. It's really bad, but they're delicious. So I really enjoyed working at County. They just run things a little bit differently. Sometimes you'll have Rush residents, sometimes you'll have the County residents, and it's just a different socioeconomic backgrounds, if they have insurance or not. So you're just dealing with a lot of different people, and I think it's super interesting. And I did neuro and psych there, as well as a month in medicine, and I loved all of them. I loved working at Rush too, but it was definitely cool to get feeling their different experiences at both places.
Like ready to actually do more things that you take for granted at Rush?
Like what?
Like blood draws, like even transporting patients for surgery. I mean, sometimes you're going to be asked to do that because no one else will be available or hasn't gotten around to doing it.
County's crazier.
In what way?
You see a lot more interesting things. It's really sick people.
I got super good at blood draws there because I did like 3 a day. Because I volunteered for everyone's blood draw, and then by the end, I thought I was really good at it.
It's the best rotation of the year. The teaching's outstanding. You have a lot of autonomy, and you have a lot of patience. It was really great.
Find a way to contribute to the team. It makes you feel better, and it also is going to help everybody else, and it's going to make your attending like you. So the residents feel like it's a flip of the coin, whether you're going to slow them down and irritate the hell out of them, or whether you're going to help. So find a way to be useful. I will look that up. I will make that phone call. Let me go do this. Let me see if I can make the appointment for Mrs. Smith, that kind of thing. is great. Let me run back in the room and explain to them. Let me print out that patient education material on diabetes, and that's a great thing for you guys to do. You look it up, you print it out and hand it to them. Make yourself useful.
I think one of the best things you can do in that vein is pay attention on rounds to the patients. So if you hear that your resident and senior or attending say that this person needs serial abdominal exams every 2 hours, rather than have them remind you and find you in the call room and go, hey, did you do abdominal exams? If you were to go report to them at the middle of the day, yeah, I've done serial abdominal exams on this patient and there's been a change, they don't feel as distended, blah, blah, blah. They really appreciate that, because that not only shows initiative, but that actually, saves them time too, because that gives them a better idea of what's going on. So just pay attention on rounds and be proactive.
And don't be afraid to ask. Ask questions, ask to see a patient, ask a physician, attending, or resident to verify a physical exam finding or to show you a physical exam finding that might not be on their patient. So see your patients twice, 3 times a day, follow up on them, talk to them, talk to the family. Most of the families look to the students as really first contact and are more comfortable talking to them than the other people on the group.
And what happens if the attending asks you a question you don't know?
Say you don't know.
And then what do you say?
But I'll look it up.
The biggest advantage student has over the rest of the teams, the physicians, the residents, is that they are closest to basic science teaching. So we use the students a lot as resources on brushing up on or teaching us on pharmacology and physiology and anatomy.
How do you get feedback?
It comes in multiple forms. Sometimes it's just verbal. Every once in a while you get a good job, or I'd prefer you do this next time. We have feedback cards. You'll get those as well, filled out, read those, follow those. And yeah, that's pretty much it.
Well, usually your grades are split between attending evaluations, resident evaluations, usually some sort of various projects like presentations or papers you have to turn in, and then the shelf. The shelf is always 25% of a card, and they rate you 1 to 4 on various things, basically being like 1 is you never really knew what was going on, 4 being like you're outstanding, and it's very lenient. Most people get pass. It's like 50% of the class gets pass, and then 30%-ish get high pass, and then 20 to 10% get honors.
Some residents tell you this is what I want. Some residents are just nice and like you're getting along with well and you're just doing everything and they just get it. And then sometimes like you get thrown a curveball and like apparently they just don't like what you're doing and they don't tell you about it. So it's kind of your job, and that's where the feedback cards come in. It's nice if you have a resident you're having problems reading, you can use that as a way to be like, so am I doing okay? Do I need to do anything different? And then that's a really good way to get that answer.
Dr. Ken, I'm like, can you fill out one of these for the camcorder job?
Yeah.
So.
Is it fairly common to drop a baby?
I only dropped 2.
Yeah. So is that acceptable number? I mean, what's the cutoff in terms of passing? 2?
2, yeah. I'm a little clumsy.
2 or less, you're fine.
You're golden.
Got it. Thanks.
I didn't drop any babies.
Well, la-dee-da.
I would say
Relax.
Yeah.
Don't stress. Everybody understands you're brand new.
Yeah.
Mina, one piece of advice to the M3s.
Have fun. It's like so much better than second year, and it's like it's a lot of fun. And it goes by extremely fast. So if you think it's just dragging, just wait. And before you know it, you'll be in F4.
Alex?
I don't know what to add to that. I wish I hadn't called my pager a beeper. That's what Dr. Dre calls it.
Dr. Dre says beeper.
Beeper, right?
We kept beeping.
Right.
I kept
and that's the only reason I went to
That's
medical
the best
school.
advice I think. Yeah. I would say, I'm sure the month that you studied for Step 1 probably felt like the slowest month of your life, but Mina's right, this flies by. It's like finally getting to do what you thought you were coming to med school to do. So just enjoy. It's going to be great. Your life's a lot different starting now for the rest of your life, which is awesome.